Hello, I'm Dr. Brant Thayer. I'm a PGY3 in the Department of Psychiatry at Creighton here in Phoenix. I'd like to thank you on behalf of myself as well as my attending, Dr. Gwen Levitt, for selecting this presentation to review on atherosclerotic cardiovascular disease score and inpatient psychiatric management. First, by way of background, individuals with serious mental illness are thought to suffer somewhere between 10 to 25 years of life lost compared to the general public. Of those years of life lost, it's estimated that somewhere between 17 and 22% of those years are due to cardiovascular disease. Also, the American Heart Association and the American College of Cardiologists have jointly developed a tool to risk stratify those that would benefit from use of a lipid-lowering medication, a statin, for the use of primary prevention of cardiovascular disease. Cardiovascular disease being defined as either a non-fatal heart attack, fatal heart attack, or stroke. The ASCVD score predicts the risk of any of those cardiovascular events occurring over the next 10 years. It does this using a variety of variables, which you can see here listed below. One way this could be explained to patients is by saying that a score of 8% indicates that if 100 individuals that had the exact same variables, the same blood pressure, the same smoking status, the same diabetes status, if we had 100 individuals that were exactly the same as you, 8 people would go on to develop a heart attack, and then a statin could be used to mitigate that risk. The different buckets that the ASCVD score puts people into is those at low risk. Those patients would generally benefit from a Mediterranean diet, all of us would. Those at borderline risk, these are individuals that most likely would not benefit from a statin, though if there are some factors such as a personal family history of cardiac disease, chronic renal failure, metabolic syndrome, other things that would increase an individual's risk and not be calculated as part of the score, those individuals might benefit from a statin. And then those at either intermediate to high risk, a statin is recommended. At our hospital system, we've implemented a 2-phase system to reduce the cardiovascular risk profile for those patients that have been admitted here. Phase 1 involved the education of providers as well as increased visibility of the ASCVD score. We use our EMR to populate the ASCVD score into our main daily notes, as well as into a variety of views into the patient's chart. The data that you will see in the following slides is from our Phase 1 approach. Phase 2 included implementing a best practice alert. So when you click onto somebody's chart, if someone has a score in intermediate to high risk category and they would benefit from primary prevention, meaning they haven't already had a stroke or cardiovascular event of some other nature, then a best practice alert comes up and the provider has to do something with that score before proceeding on. And so that data will be available in the future. We're currently collecting it. So we did an inpatient chart review, a retrospective chart review from March through November, a total of 175 patients, most of which were male. And of those, 140 patients had scores in the intermediate to high range, the average score being 14.9. Most of those patients were white or non-Hispanic, with the largest single majority being other for the different races, some mix of Asian, Middle Eastern, or unidentified. Of those 140 patients that were admitted, 55 of them were on a statin admission, meaning that when they arrived, they were prescribed a statin. Of those 140 patients, 25 were started on a statin within 24 hours of a result being available. This might be a little bit different than when they arrived because their lipid scores might not yet be available. So it would be 24 hours from when a score was reviewed. Unfortunately, 93 of our 140 patients were not prescribed a statin, and 13 of them were at high risk, meaning that they had an ASCVD score of 20 or greater, and that would be 20% of having a cardiovascular event in the next 10 years. Most of these patients had some type of comorbidity, and you can see those numbers listed below. Again, many of the patients that were not prescribed statins were on or had comorbidities. So the take-home message here is that in general, as psychiatrists, we work with a population that has a much higher rate of comorbidities, often related to the medications that we prescribe. And those medications can increase the risk of premature death even compared to the general population. We may be missing opportunities to impact our patients' lifetime risk of cardiovascular disease. The ASCVD score is a relatively simple tool. There's calculators commonly available on the internet. Some EMRs even calculate this on its own. And statin drugs are readily available and have a low side effect profile. I'd like to thank you for your time. If you're interested, here are our resources. You can also contact Dr. Levitt or myself with any questions.